Hello, let's talk about pancreatic cancer. It's a big killer because it's tough to recognize and it's tough to get out of there. Now, the position of the pancreas relative to the vasculature of the upper abdominal cavity contributes to the fact that it is pretty hard to get out of there. Remember that your pancreas is a retroperitoneal organ that connects at its head to the duodenum, and its tail is attached to the spleen, and running directly behind the pancreas is going to be, on the left side, your splenic artery, and on the right side, your common hepatic artery. So those are two important named arteries that a tumor, if it's growing in the head or the tail of the pancreas, might compress that artery or start to invade into that artery, complicating resection. Now, remember that your pancreas is also immediately anterior to the superior mesenteric artery and veins, and by extension of those, the aorta and the inferior vena cava. So its position right there also contributes to complicating resections of tumors that have potentially invaded those vessels. Generally, remember that your pancreas is a majority exocrine organ and that its glandular architecture consists of secretory acinar cells that are arranged in clumps or spherules, and centroacinar cells in the middle of such globes of acinar cells. Centroacinar cells are ductal cells that represent the start of the ductal network, or the smallest possible ducts. And ducts get bigger and bigger and bigger, and you see here on the left, here is a duct that's probably a intralobular duct. You can tell it's got a cuboidal endothelium on it, and it's kind of anchored in place by a lot of collagen. So that's a normal duct sitting in your normal pancreas. And I'd like to take one more look. I got a color photo here. Here we've got a normal duct on the left side of this screen. Notice the simple cuboidal endothelium on it. That's the cell that turns cancerous in a ductal adenocarcinoma. Over here on the right, we see an islet of Langerhans, which is going to contain, amongst other things, alpha cells that make glucagon and beta cells that make insulin. Now, those tumors are not covered in this SDL, but I wouldn't throw it past them to try to sneak a fastball by you on that pitch, right? Because they could totally ask you about an insulinoma and a glucagonoma, and you're expected at this point to know that's the cell type, that's the location it comes from, what sort of symptoms would it have. You should be able to connect the dots on those too. So I wouldn't rule it out for this exam. And then the rest of this slide, what you're seeing here, just in the middle of everything, that's acinar tissue. So it's purple more so than pink, and it makes a lot of proteins, enzymes like trypsin, elastase, etc. So that's the normal pancreas. Most of the cancers we're about to talk about are coming from ducts like that. So ductal adenocarcinomas account for about 9 out of 10 pancreatic cancers. Some have acinar differentiation, which is at the bottom of this SDL. Some have neuroendocrine differentiation, which again is not covered in this SDL, but I wouldn't put it past him to ask you a question about a gastronoma. We've already seen a gastronoma, you know, that's Zollinger-Ellison syndrome, right? So I want to talk about the VIPoma and the somatostatinoma, because those are two particular hormones involved in the gut that you might not know too much about because they're not insulin and they're not glucagon, you know, they're not the heavy hitters. So VIP is vasoactive intestinal peptide, and it relaxes skeletal muscle of the bowel, or smooth muscle. And this is the same VIP that's going to facilitate relaxation of the lower esophageal sphincter to let food into the stomach. So if you have a VIPoma that's making way too much VIP, what that means is that your bowels are dilated and atonic and they cannot contract. And so the primary presenting symptom of a VIPoma is diarrhea, which is going to lead to ion disturbances and dehydration because you're not able to contract your intestines to hold food in there for long enough to really absorb things from them. And so you're just going to lose food mass and fluid in that VIPoma. Somatostatin is a GI hormone that plays the role of stopping the production of all other GI hormones. So when you got somatostatin on the block, everybody else goes inside, you know, he's like Debo. So somatostatin particularly, amongst all the other hormones, stops cholecystokinin. So if you stop cholecystokinin, what that means is that you're not going to have gallbladder contractions. And as a result, cholesterol inside the gallbladder and bile are going to have more of a holding time within that gallbladder. They're going to be allowed to interact with one another for longer and longer and longer, and eventually they're just going to get crusty and crystallize up in there. And that's going to give you gallstones, cholelithiasis, because you're not moving bile out. So the longer it sits in pools, the harder and harder and more solid it gets, because your gallbladder is just constantly pulling fluid out of that lumen. Remember, with sodium active transport and chloride follows. And so that's how you get gallstones if you don't empty your gallbladder because you don't have CCK, because you've got a somatostatinoma. So the primary symptom of that you will not see in any other tumor on this list over here, these other four besides somatostatinoma are not going to give you gallstones, and they are not going to give you a bile acid insufficiency steatorrhea or fat malabsorption that's going to present with pale stools, because remember, stercobilin that adds color and pigment to your stools is produced from conjugated bile acids. And if you're not getting bile acids out because you don't have CCK, because you have too much somatostatin, you're going to have fat malabsorption. So let's talk about risk factors for pancreatic cancer. And again, when we say pancreatic cancer, until the end of this SDL, when we get into Acinar cells, we are talking about pancreatic ductal adenocarcinomas, PDACs for short. Now, it's the 10th most common cancer in the US, but it is the number 4 leading cause of cancer-related deaths, and that is continuing to go up as we get better at treating other cancers, but our ability to treat pancreatic adenocarcinoma stays relatively the same. It's got a very poor 5-year survival rate, again, owing to the proximity of some very major vessels around the pancreas and the proclivity of that tumor to grow into those vessels, including the superior mesenteric artery and vein, which supplies the entire foregut, you know, and if you just take out the foregut, you're going to have a tough time living. So what contributes to pancreatic cancer? Some environmental factors, which I'll talk about first. Smoking is the most common acquired risk factor for pancreatic carcinoma, but if they say what's the strongest, I feel like they wouldn't word it like that. But if I were writing the question, I might ask you, you know, there's a difference between most common and most important, you know, and so if they ask for what's got the greatest risk, it's chronic pancreatitis, because we look over here at the table, and if you have chronic pancreatitis, you've got a 13-fold chance of acquiring pancreatic cancer. And if you remember from that last SDL about pancreatitis, your rate of developing cancer is about 5% in that chronic pancreatitis population, which is drastic compared to normal. So again, pancreatitis, the most significant. Tobacco increases your risk about 200%, most common. Now, we've also got some hereditary factors for pancreatic cancer. And I imagine that any question they ask about this, they'll give you the syndrome and they'll ask you to pick the corresponding gene out of A, B, C, D, E. And they could flip that. They could say, patient's got this pancreatic cancer. They've got a different primary tumor, perhaps in the breast, and then they've got a BRCA2 mutation. And then you'd have to narrow it down and say, okay, is that Lynch syndrome or is that hereditary breast and ovarian cancer syndrome? Because you can also get Lynch in the breast, right? So you'd have to make the diagnosis, okay, hereditary breast and ovarian syndrome, check. So that's how that question is going to get asked. You got to memorize these genes. I've laid them out on the side of this table so that you see them right next to the name of the diagnosis. That Peutz-Jeghers, don't forget that's going to be small intestinal polyps. And in Peutz-Jeghers, you're also going to see blue-brown macular, that means flat spots on the lip and face, and that's that STK11 gene, which imposters as liver kinase B1. That's the other name for it. So get your brain going, because we are just getting started with the genetic component of this SDL. This thing is all genes. And you can do it. You can memorize them all. Precursor lesions. So remember, colorectal cancer, what's the precursor lesion to that? Well, it's the polyp, the benign polyp. And so just like you can have a polyp before you have a cancer of the colon, you can have a growth inside the pancreas before you get full-blown ductal cancer. And it's not as easy to imagine the shape of, because the pancreas is kind of an amorphous organ, you know, and it's not as well defined grossly, so we don't know as much about it, because these things are harder to find in patients, because again, that pancreatic cancer presentation of isn't obvious like it is in colorectal cancer, where you might get a hematochezia or an obstruction of the bowel. No such thing is going on in this pancreatic cancer, so very often we catch them after the precursor lesions have developed. Now, this sequence of pancreatic intraepithelial neoplasia, PANINs, the sequence is important, because you go PANIN 1 to PANIN 2 to PANIN 3 to cancer. And there's particular mutations associated with each step, each individual PANIN. So this I'm trying to think of a particular word. This picture with 4 smaller pictures. There's got to be a better word for that. I just can't think of it right now. This picture with 4 smaller pictures. In the upper right quadrant, they're showing you a PANIN 1. And what you need to know for the test is that this dude has a KRAS mutation, okay? Period. PANIN 1 KRAS mutation. Now, if they show you a PANIN 2, in Roman numerals and in Arabic, if they show you a PANIN 2, this dude has picked up a P16 mutation, okay? Now, if they show you a PANIN 3, as is in the lower right quadrant of this, there's got to be a word for what this is, this arrangement of 4 squares. Why am I blanking? It's like a window pane almost. If they show you a PANIN 3, what you need to know for the exam is that that PANIN 3 has already had a KRAS and a P16 mutation. But to push it from 2 into 3, it has picked up a P53 mutation and possibly a DPC4 mutation. So that's the sequence, the arrangement of genes corresponding to the gross morphology of these precancerous lesions. And obviously, well, maybe not obviously, but the shape of the cells that you see on histology is determined by the contents of that cell's DNA. So they correspond and overlap. You got to know all these mutations, period. So we said we start with KRAS, which is an oncogene, meaning that there's going to be a gain of function mutation in KRAS. That's carcinogenic. KRAS binds to a GTPase to activate the MAP kinase pathway, and that stands for mitogen activated protein kinase. So a mitogen is anything that puts the cell into mitosis, okay? A slang term for mitogen is growth factor. So an activating mutation in your KRAS receptor means that it's stuck on. It can't turn off. You know, it can't turn down. It's going to turn down for absolutely nothing. So this KRAS gene is just constantly sending mitogenic signals down to the DNA, which is going to say, oh man, I need to hurry up and get into S phase. So this initial KRAS mutation allows for a cell to become self-sufficient. You know, some of you might be financially independent, and some of you might still be living off your parents' buck. And I'm not going to make a comment as to the ethics or morality of that. It's just a statement of fact, you know. And so everyone wants to become financially independent. Well, this KRAS mutation is analogous at the cellular level to a person obtaining financial independence. They don't have to sit and wait around for a paycheck. They've got money. So that's why it's the first one, because you need money before you can do anything, you know. This cyclin-dependent kinase inhibitor 2A, also known as INK2A, P16, what this is going to do is this is going to make a cell insensitive to anti-growth signals. So if you're turning too far up, you know, your neighbor might come knock on your door and say, hey, can you please turn the music down? And so cyclin-dependent kinase inhibitor 2A or P16, normally P16 is like, oh yeah, sure, we'll turn the music down, you know. But if P16 is not there, then the cell is free to say, up yours, man, you know, like we're gonna party all night long. So P16, that's a tumor suppressor gene, meaning we're gonna have a loss of function there. P53, remember what P53 does. It normally, if you get a lot of P53, tells the cell stop, think about what you're doing, and that stop presents the opportunity for a cell to run the apoptosis program if it needs to. Now, if you don't have the P53, you don't stop. You don't take stock of your position and surroundings and state. And if you don't do that, you could have all these DNA mutations and it wouldn't matter, you know, because you wouldn't be able to run the apoptosis program as you should whenever a cell has accrued mutations. So P53 is a big stop sign. You lose P53, carcinogenic. It's a tumor suppressor gene. DPC4, also known as SMAD4, is another tumor suppressor gene. It's lost in Panin-3 lesions and half of invasive ductal adenocarcinomas. This DPC4 is going to block TGF-beta signaling. And TGF-beta normally serves a similar function to P53. It says stop, reevaluate, look at where you are, take stock. Do you need to grow more? Do you need to run apoptosis? So if you don't have TGF-beta, you can't do that, which is why DPC4 is a tumor suppressor gene. Now remember, here's the words. This whole thing's the words, but the words are arranged in a sequential order, meaning this KRAS, you see KRAS mutations in Panin-1s. You see P16 mutations in Panin-2s. You see P53 mutations and DPC4 mutations in Panin-3s. So it's 1 to 2 to 3, right? And then to full-blown cancer after that. And so BRCA2 is going to be a late mutation that you pick up, typically right before you go into that adenocarcinoma or possibly after you've even reached that stage. BRCA is another tumor suppressor. That can be something real simple, you know, which one of these is an oncogene, tumor suppressor gene, etc. And then APC is brought up briefly at the bottom to alert you of the fact that pancreatic ductal adenocarcinomas do not express APC. So don't pick that. If it's an acinic cell carcinoma, you can pick APC. Those all have APC mutations. If it's colorectal that's metastasized possibly to the pancreas or the liver, you might see APC mutations, but you're not going to see it in the ductal adenocarcinoma, which is the majority of pancreatic cancers. So going back and looking again at these precancerous lesions, we see normal in quadrant A, and it's just got a single cuboidal epithelial endothelial layer. Then we look at a Panin-1 and we see there's some hyperplasia of that endothelial layer. It's really puffed up and there's a lot of cells in there. Then we are looking at a Panin-2 and we're starting to see this columnar transition. And let me tell you, Your pancreatic ducts normally should have cuboidal epithelium, and the second you start to see columnar, that shouldn't be there. They should be squares, not big, tall rectangles, not skyscrapers. So you see that, you know, that's a little bit of metaplasia, dysplasia transition going on there. And then Panin 3 starts to get really messed up, and you start to see this gland-on-gland architecture. You know, it's like your duct has ducts, is what I'm trying to say. You see microlumens adjacent to the big lumen. They're like cystic spaces, and that's called cribiform architecture. So if you see this cribiform architecture, that's basically Swiss cheese, you know, then you're going to say, oh, that is a Panin 3, not a Panin 2, because a Panin 2 is columnar cells. Not a Panin 1, because a Panin 1 don't even have columnar cells, let alone cribiform changes, but it's just got a hyperplasia of that ductwork. And it's certainly not normal, because that would just be one row of cuboidal epithelium. So this is a good timeline showing you first you got to get a KRAS mutation corresponding to the Panin 1 stage of change. Then you pick up a P16 mutation that corresponds to Panin 2 precursor lesions. And remember, that's also your inhibitor kinase 2A, CDKN2A. And then the transition from Panin 2 to Panin 3 is characterized by the acquisition of a P53 mutation, a DPC4 mutation, or a BRCA2 mutation. And you are not going to see these mutations unless it's a Panin 3 or full-blown ductal adenocarcinoma. So, because we know the sequence and the steps and the genes, do you think you're going to get a question about this somehow, some way? I think so. Here is a little bit cleaner slide looking at the same thing with some histology correlates. Again, we're looking at simple hyperplasia in a Panin 1. In Panin 2, we start to see nuclear abnormalities characteristic of dysplasia. In a Panin 3, you start to see that cribiform microcystic architecture, okay? And then in an adenocarcinoma, that's going to hell in a handbasket. So we look at the timeline. What do we have here? You got a normal duct, and the first thing it gets is a KRAS mutation. Then the next thing it gets is a P16 mutation. And so that's good enough to get you into the Panin 2 stage. Once you get into the Panin 2 stage, remember, the only way you're going to Panin 3 is if you're picking up a gene that confers resistance to apoptosis, because KRAS is a growth factor gene. It's a pro-growth gene. And INC4A, remember, like neighbor says you're too loud, P16, if you don't have it, it's like, all right, go back home. We're going to keep being loud. So that makes you resistant to anti-growth signals. Neither of those have anything to do with apoptosis, though, right? So to progress into a tumor, you can think about it that a Panin 1 and a Panin 2, those things are just multiplying, copying themselves at a way quicker rate than normal cells. But until you get to Panin 3, those cells, a lot of them are still going to die because they're going to commit apoptosis, even though they had that extra growth mutation. Even though they're shielded from anti-growth circulating factors, they still have P53 intact, so they still have a good chance of being able to cull the damage. When you lose P53, not only do you have cells that are worked up, they've got a lot of money, you know, they've got a lot of growth factor that they're not dependent on circulating growth factors, but then you throw in the ability to resist apoptosis, and it's basically cancer after that. That Panin 3 stage does not last long. And it's that TP53 or possibly, again, that SMAD4, DPC4, or that BRCA2 that's going to give you anti-apoptotic properties. This is looking at a adenocarcinoma that's right next to the main pancreatic duct, right next to the ampulla of Vater, actually, because this is going to be our major duodenal papilla here on the left-hand side, And then right through here is where our ampulla is, where the bile duct would connect with the pancreatic duct. And so this is how you get jaundice. That's why I included this slide, you know, because you can imagine that this thing gets real tight and it becomes easier for a gallstone to just block up that ampulla, and there's your obstructive jaundice with a conjugated hyperbilirubinemia. That's a common presenting symptom of pancreatic cancer as well as pancreatitis, because most pancreatic cancers tend to be in the head of the pancreas. Here's some more looks at that Panin precursor lesion. Dysplasia and nuclear changes are going to be what characterize that Panin 2. That Panin 1 has kind of a light appearance and a washed out appearance. Every time we've seen Panin 1, they're kind of empty looking cells that just have big cytoplasm, which makes sense because the only mutation that they've had is a KRAS mutation that lets them grow faster, but their nuclei are going to be normal nuclei. That Panin 2, now they've got normal nuclei because they're growing at such a fast rate there. And then Panin 3, cribiform architecture, Swiss cheese, holes, microcysts. Here's a low mag image of a ductal adenocarcinoma. On the left side of that square, you're seeing the bile duct and the pancreatic duct right there. And so you know that just left where this A is going to be your ampulla of Vater emptying into the duodenum. Now, purple tissue down here, that is all relatively normal exocrine pancreas. And those purple cells are acinar cells that make all of your enzymes, your pancreatic lipases and proteases. Over to the far right side of this image is where the cancer starts. And it's a ductal adenocarcinoma. And the reason it's pink and not purple is because there's a lot of fibrosity and scarring and intracellular collagen being laid down. And we call that a serous appearance or a desmoplastic reaction. Now, let me see if I can find that in the text before we go any farther. Here we go. So as we talked about, ductal adenocarcinomas, majority of them pop up in the pancreatic head, probably has something to do with increased incidence of bile stones there in the head. Grossly, you're looking at a gross tumor, the only way to say it. It's serous, it's got scar tissue, it's sclerotic and dense and thick. Direct invasion of the common bile duct and duodenum is common, okay? So you got to take out any tissue that's been invaded by this cancer. And again, if it gets into certain arteries, what are you going to do, take out the superior mesenteric and put it back on? I don't think so. That's practically impossible to do meaningfully to where it doesn't have long-term implications. And these tumors tend to grow in the head. They tend to have a lot of fibrous tissue, and there are some subtypes. That's where I'm going next. And you need to know the subtypes because they determine the prognosis of pancreatic cancer. And 2 years, 5 years, 10 years, that's a big difference. And so some of these cancers are more generous than others. They'll give you a little bit longer lifespan. Some of these cancers take a little bit more than others. And especially where they're growing, you know, that's just as important as what type of cancer is it. So this sentence at the bottom of page 6 is really nice. Microscopically, well-differentiated conventional pancreatic ductal adenocarcinoma is characterized by proliferation of small tubular structures producing mucin lined by cuboidal mucinous cells in abundant desmoplastic stroma. So the most important visual cue there is going to be the abundant desmoplastic stroma, because you're going to look at all the scar tissue in this histology slide and you're going to say, that's not a normal pancreas, period. And so then the differential between subtypes of a ductal adenocarcinoma is going to be based on, is there mucus there? How much mucus? What do these individual ductal cells look like? But generally, the whole diagnosis histologically of pancreatic cancer should not be hard to make. Before we get back to looking at some pictures, All the collagen comes from primarily transforming growth factor beta. Remember, that's the same cytokine that stops your cell cycle so that you can choose to divide or commit apoptosis if you need to. It's a damage-related cytokine. It's produced by M2 macrophages. Whenever you have that polarization of macrophages, you know, you can go M1 or M2, and M1 is your acute damage phase, and M2 is your cleanup phase. It's the, we've taken care of potential pathogens. We've laid down, let's start to lay down some scar tissue so that we can close this off and restore some normalcy to this area. And TGF-beta is the translational molecule that sends that message. And so TGF-beta gets into an injured cell. And if it's too injured, then it just needs to go ahead and apoptosis, right? But if it's got a little bit of leg left to it, you know, you can just divide that cell and it'll heal on its own. So that's the role of TGF-beta. Finally, the last two important points in the middle of page 7 here. Invasive ductal adenocarcinoma can spread in any way, but something that's peculiar to the pancreas is this perineural route of invasion, meaning it can get into a nerve sheath, into that nerve bundle. Remember, a nerve is fibers in a cable wrapped by perineurium. So it can get into the perineurium and spread down the nerve system that way. Then you have your lymphatic and vascular spread, traditional. The liver is the most common side of pancreatic metastasis owing to the portal vein. Back to some visuals. Here's a really high mag ductal adenocarcinoma. Where you're really seeing it is on the right-hand side of this ductal epithelium. And remember that cuboidal epithelial cell, that's the cancerous cell in question here. You can tell there's a lot of dysplasia. There's a great degree of hyperchromasia, meaning very dark nuclei. In particular, again, that segment of cells there on the right side of that duct, they're proliferating like rabbits. And notice the desmoplastic stroma, which is basically everything outside the duct in the middle. You understand at this point. You're looking at collagen, you're looking at fibroblasts, you're looking at extracellular matrix there. We're seeing spindle cells, right? They're shaped like they've got points on each end. Those are your fibroblasts, myofibroblasts, stellate type cells. You have stellate cells in your pancreas too, remember? You have stellate cells in your liver, and that's what gives you cirrhosis, because the stellate cells turn into myofibroblasts. They evolve and differentiate, and then they start laying down collagen when TGF-beta tells them to do that. That's how you get the fibrosis. A little bit zoomed out. Right side of the screen, we've got our pancreatic ductal adenocarcinoma. There is just too many cells in that duct lining, and they are all fat and swollen and hyperchromatic, and their nuclei are showing some speckled changes. That's not a normal ductal epithelial cell. Now, right here, we've got a normal structure. You know what this is? That architecture is of an islet of Langerhans. And so you see some alpha cells down in there that are staining very darkly. And then the majority of those cells are going to be beta cells if they're staining a little bit more pale. And those alpha cells are making glucagon, and the beta cells are making insulin. And coincidentally, with a larger and larger and larger tumor, you're going to knock off more and more and more islets of Langerhans, which means that diabetes is commonly associated with pancreatic cancer, because you're bopping the cells that make insulin. And that's actually referred to as a type 3 diabetes. Remember, when it's associated with pancreatic damage, direct damage to that organ. Another ductal adenocarcinoma. Yo, I found this dude's Twitter account at Panc Pathologist, and I kid you not, this dude spends his whole life just like hitting the interwebs with pancreatic pathology. And so I'm like, salute, yo, like you just made my job, our jobs, just so much more beautiful and fun, because these are great images that I found. So if you use the Twitter, unlike me, give him a follow. He's a really nice guy, very happy to be a pathologist. So this is our perineural invasion. We're starting to see a little bit of nerve cells right there, nerve cells right there. And again, perineural is within that perineural sheath. We're also seeing a ton of fibrosity within this ductal adenocarcinoma. It's basically pale light baby pink staining area with spindle-shaped cells and sparse nuclei. That's your desmoplastic stroma. Another paint pathologist slide that he pulled out with a needle biopsy, fine needle aspiration, which is the gold standard diagnosis for getting this pancreatic cancer sampled, because you're obviously not going to open a patient up and take a sliver of the pancreas. You're going to stick a needle in them and pop. So high degree of desmoplastic change there on the right, more on the left. Again, it's pretty anuclear. And notice these strips of adenocarcinoma right here in the middle of this image. That's the cancer. That's the cancerous cell. And you can especially tell down at the bottom here, I mean, that there's a lot of cell division going on there. And this sucker here on the left-hand side is also particularly proliferative. So you can tell that's the cancer. Everything else is just the tissue reaction to the cancer. Got it. Perineural invasion, great, great slide. Yo, nerve, very clearly, big nerve bundle. And so it's wrapped in a coat of perineurium. And here is your ductal adenocarcinoma inside that perineural bundle. And it's kind of shaped like a glomerular crescent here. But you can tell those are our cuboidal transitioning into columnars that become more dysplastic, pancreatic ductal cells that are the cell of cancer in adenocarcinoma. And then you can kind of sort of see the perineurium going around and investing around all those tissues. So that's exactly what we mean by perineural invasion. Here's another example. Here's your perineurium. You can see the perineurium better. It's kind of red-pink in this image here. And it's going all the way around that nerve bundle and most of the tumor. And you can see over on the right-hand side of this circle where the cancerous ductal cells have squeezed their way, encroached into that perineurium. And then you can see the poor nerve here is just so crowded. And that's the source of a lot of pain. And it's not going to go away easily, you know. And so that's going to be typically visceral pain, because this is going to be a C unmyelinated fiber, and it's going to radiate to your T5 through T9 dermatomes. Could be the front or the back. Now we start getting into different subtypes of ductal adenocarcinoma. So we've looked at normal, and normal is going to be, it's normal for a reason, you know. So these subtypes are rare. The one you really want to know is the medullary carcinoma, because that's got this big association with Lynch syndrome. Remember, we said if you get Lynch syndrome, you're more likely to get a particular pancreatic cancer. So let me walk this back. They could also ask you from this table, they could say, patient's got a PMS2 mutation, okay? What's their pancreatic cancer going to look like histologically? Oh, my word. And so that's like the third order question there, because you got to say, all right, PMS2, Lynch syndrome. Lynch syndrome, what do they get? What do they get? What do they get? Medullary glandular cancer. And so then you got to think about the histology of that, and you're going to say, okay, it's medullary. These ductal cancer cells are going to be in sheets with big prominent nuclei. There you go. So that's the line of questioning they want to ask you here. So let's look at this medullary carcinoma first while it is at the front of your mind, because it is, again, more important than these other subtypes. We're looking at a sheet of polygonal cells with big fat nuclei. And when we say a sheet, what that means is that you sliced the tissue and you look at it, and all these cells are in the same plane. There's not some going into the screen. There's not some coming out of the screen. They're all in the same, you know, geometric plane. So you can trace the margin around this medullary cancer of the pancreas. And what's this big pink material is, this eosinophilic bright pink material, is basically necrosis, because you can tell there's no nuclei at all in that hot pink region. So again, the association is Lynch syndrome. What's it look like? Sheets of cells with a lot of cytoplasm and big fat nuclei. Same exact thing. That is a sheet of cells if I've ever seen one, you know. You ever see the word sheet and it's like that? That's what it looks like. So you can see definitely some nuclear changes. Those cells, I mean, that cell's nothing but nucleus. So we've got nuclear swelling and hyperchromasia with some mitotic figures observed. There's a mitotic spindle. That thing's got 3 of them, you know, that's a trisomy. So these cells, largely, they're kind of fried egg in appearance. Don't mistake this for an acinar carcinoma, okay? Because an acinar cell carcinoma, well, it pops up at the end of the SDL, but those are also big purple cells that are swollen with zymogen granules because they're making proteins. And in that case, those will be purple because they're basophilic and they are making a lot of proteins. But this is a ductal adenocarcinoma. It's a medullary subtype, and it's associated with Lynch syndrome, which is your MLH1, MSH2, MSH6, and PMS2. So these other variants, we'll take a look at them, a couple of looks at them. Colloid carcinoma, that's going to be cash money. Signet ring type cells with a bunch of mucin. Here's what one looks like. Again, just very, very abundant mucin. So the challenge for this is going to be a confounding answer choice when they give you a question about a pancreatic cyst, okay? Because this is not a cyst. And you know it's not a cyst because here's the cancer, like right there in dark purple, just a very swollen duct that's got dark, dark, dark nuclear changes and all this fibrous stroma, this desmoplastic change around it. That is not a cyst. But the mucinous colloid component might make you think it's a cyst. Same look here. Very clearly cancer on the lower right fringe of that dilated space. And within the cystic cavity on the left, very clearly filled with mucin. You know, mucin's got that kind of gray appearance to it, like baby snot. Neoplastic cells suspended in extracellular mucin. You can tell something pathological is going on. You see some spindle cells and fibrous stroma. But the cancer is right there in the middle. And so you're going to say that is a ductal carcinoma, not a cyst. What else do we have? We've got the adenosquamous carcinoma, which has a biphasic composition, but there's nothing specific they can ask you about the adenosquamous carcinoma, so I don't think they'll waste a question on that. Here is a good example of one having both the squamous phase in that bright eosinophilic pink and the glandular phase that I'll circle in green, very clearly glandular. So it's going to have both of those tissue types within it. And here's another example. The cancer is really right here in the middle, kind of going horizontally across that screen on the left. And so we've taken a slice that's right next door to it, the very next section, and we've immunostained it for a squamous marker. And so you can tell that some of these cells are lighting up for squamous differentiation. We can highlight those in yellow here. But then other cells are not. And so, like, we'll use green for your non-squamous cell component, basically going around the lip of the gland over here, or the duct, I should say. And so if we take what we know about the squamous composition and apply it to the image on the left, we know that the cells that are surrounding the duct over here, that's your normal ductal adeno component. And then you've got a big chunk of squamous cells up over here on the right. And a little bit down here as well, with some, again, glandular cells admixed. Over here again too, you can tell it's not picking up stain. You just need to compare the two sides. So you can also have a hepatoid carcinoma in the pancreas, which is going to be like the liver, but not quite the liver. And you need to remember that the liver and the pancreas come from the exact same tissue, endodermic foregut tissue. And so it's going to look like liver. You ought to know what liver looks like by now. Large polygonal cells. No great way for me to tell you how to tell it apart from a medullary carcinoma. This is a lot less common. And again, there's nothing specific they want to ask you about this one. There's just nothing to ask you about it other than like, here it is. And again, they probably would not just ask a question about it. Undifferentiated carcinoma. This is going to be a just look at it and make the call. Does it look like anything? No, not really. Okay, undifferentiated. And then you have an undifferentiated with osteoclast-like giant cells. And we believe that there are going to be osteoclast-like cells there due to some sort of paraneoplastic syndrome. I'm thinking potentially a parathyroid hormone, because that's going to work to pull calcium out of your bones normally, right? And phosphate too. And so when you're doing that, the only cell that's capable of it affecting that is the osteoclast. And remember also that osteoclasts, just a quick review, are activated by macrophage, MCSF, I think the M stands for myeloid, MCSF, and rank ligand binding rank, and that's your receptor activator of nuclear factor kappa beta. And so osteoclasts are going to chew up bone to release calcium and phosphate. Now, these dudes have KRAS mutations, these tumors do, and there's an undifferentiated carcinoma. Again, you can tell there's no ductal component to it. It's just a bunch of spindle cells. Here's your osteoclast-like giant cells. Really pretty pathology, you know, in that kind of eerie, transcendent way. Gives you that feeling that medicine gives you sometimes, you know, where you feel like, you know, you're there and you're you, but like for a little split second, you're not you and you're kind of above it all. It's the feeling that medicine gives me sometimes. More osteoclastoid giant cells. There's one. And you got to hunt for these guys, you know, like if you were good at I Spy as a kid, like you got this, you're golden, you know, but if you weren't, it's like, where are the giant cells? So have fun. Again, this is associated with KRAS, and oh, you do want to know that this osteoclast-like giant cell tumor has a very favorable prognosis, good prognosis, thumbs up. What's the one that doesn't have the favor? Undifferentiated is definitely going to have a poor prognosis. That's going to be aggressive. So we're through the histological subtypes. Let's talk about clinical presentation of pancreatic cancer. You don't need to know too much about it, because again, if they really want to test you about pancreatic cancer, they're going to say the dude's got pancreatic cancer. And I mean, the pros have a hard enough time finding these things as it is. So jaundice is a common symptom. What's associated with jaundice? Dark urine, pale stool. Conjugated bilirubinemia because of the obstruction. And if you see a conjugated bilirubinemia, basically the only thing that can give you a specifically conjugated bilirubinemia is obstruction of the bile duct. You know, if it's unconjugated, it's not a problem with the bile duct because you haven't made any conjugated bilirubin yet. You haven't made any bile acids. So most patients will have high glucose intolerance, diabetes at diagnosis, and that's your type 3 again. So then we got Courvoisier's sign, past the Courvoisier. A distended and palpable gallbladder that doesn't hurt. So if it hurts, what that means is that there's gallstones, okay? If it doesn't hurt, what that means is it's just a bunch of bile in there and it's not gallstones. So hope that makes sense. If there's a bunch of bile in there and it's not gallstones, well, what can make your gallbladder fill up that drastically? Compression of the biliary tree by something else, probably a tumor. And then you might see Virchow's node, which is going to be left supraclavicular right there over the apex of the lung. And a lot of dudes like to metastasize there. Lung cancer does, gastric cancer does. Trousseau sign, you might see that. That's going to be spontaneous clotting You basically get tiny little DVTs all over the place in a random haphazard distribution that is spaced out temporally as well. So it might be at your right hip one day, and then you might get one down in your left calf 3 days later. That's like Trousseau sign, recurrent superficial thrombophlebitis. And again, it's nothing that's going to like kill you or anything. It's just a little bit of clotting leading to a bruise. Lab studies, not too important with this either, because all the diagnoses are made by histology. You know, this is where a lot of pathologists make the big bucks, is with pancreatic cancer, because the prognosis, again, is very important, and it's variable based on what type of tumor you have. That CA19-9 might let you know, hey, this is a pancreatic carcinoma in question stem. Serum amylase and lipase levels might be a little bit up because of just reactive hyperactivity of the remaining pancreatic exocrine gland. And then obstructive jaundice, again, typically #1 symptom, because most tumors are at the head of that pancreas. And lab findings associated with obstructive jaundice, I don't know how many of you know this, so I'm going to walk through it. Alk phos. Where else do we see that? Bones. And it's a measure of bone remodeling. So it's not entirely specific for liver problems, but when you see elevated alk phos, you're thinking it's a bile duct problem, not an intrahepatic problem. There's some sort of bile obstruction. Gamma glutamyl transpeptidase. That's a liver marker, and that could be elevated in alcoholic liver disease as well. And so high GGT is basically going to tell you how healthy the liver is. AST, ALT, yes, those will be up in a jaundice because bile will be backflowing into the liver and causing some hepatocyte irritation, potentially necrosis there, but it's not going to be very, very high at all. AST and ALT are more so used to diagnose a couple things. Most prominently, alcohol-related liver damage. You're going to have AST over ALT. And then #2, if it's acetaminophen toxicity, AST and ALT are going to be like 10,000. They're going to be huge, astronomical. So that alcohol-related liver disease, normally ALT is higher than AST. Just period, end of discussion, always. For some reason, I can't think of it off the top of my head, in alcohol liver damage, AST is going to be higher than ALT by about a 2-to-1 ratio. So you see that and the patient has cirrhosis, you're like, okay, they drink. And if they don't tell you they drink, they're just not telling you they drink. But the number one test for jaundice, you see jaundice, you're going to get bilirubin. And if you're unconjugated, bilirubin is high. You're going to order a conjugated bilirubin, and you're going to compare the two numbers. It's like, yeah, what's the lab workup of jaundice? You know, it's like patient comes in yellow. That's your lab workup. So on CT, this thing appears as a hypodense mass. There it is right there. I don't know. The number of times I've been told, we know you're not radiologists. We don't expect you to be a radiologist. And then they throw you just like the most random axial CT, and they're like, what is this? I don't know. But sometimes you just got to be comfortable with taking a hit, or you got to learn how to read radiology. So hope you know. Survival rate for non-resected cancer is under 6 months. And again, can we resect or not? That is predetermined by where is the cancer. Is it encroaching into any nearby vasculature? If the cancer's at the tip or the tail of the pancreas, you typically have to take out the spleen too, just to be safe. If it's at the head, you're going to take out the head of the pancreas, and you're going to do what's called a Wersing's operation, or I'm sorry, a Whipple operation, and you're going to take the tail of the pancreas and leave it in and connect it to the duodenum, and then you're going to take the pylorus of the stomach and attach it later on down the small intestine. Okay, that's our cancers. That's our ductal adenocarcinomas of the pancreas. Let's get into cystic pancreatic neoplasms. They're typically benign. A couple of them can go malignant. There's genes associated with each one. I'm going to start with this table here at page 14, and we're going to run through big points, then walk through details. A serous cystadenoma, well, what's the differential? Mucinous cystadenoma, right? So serous means it's just got totally clear fluid inside of it. Mucinous means it's got that gray, gunky, phlegmy fluid inside of it. Serous cystadenoma has microcysts. Show you that real quick. Here's a serous cystadenoma. You've got a whole bunch of tiny, tiny, tiny little bubbles. Bad photo quality, same concept. Here's a mucinous cystadenoma. You typically have a small number of these in one place. So like 1, 2, 3, 4 different lobules to that cyst or packets within it. Compared to, look at that serous cystadenoma. It's microlobular. It's got so many tiny, tiny little honeycomb spaces in there. Then we have this thing called the pancreatic mucinous neoplasm. And what's key about this is that it's connected to the pancreatic duct. And so they might tell you in words, the cyst is continuous with the pancreatic duct, and that's going to narrow it down to this. And here's another look, better look. What organ is this on the right, you know? We just mentioned it. That's your spleen. So that means this is the tail of the pancreas down here, and we're progressing towards the head of the pancreas. And so here is your main pancreatic duct right there. And so this multiloculated intrapancreatic mucinous nodule is right next to where that duct is. And it's more similar to a mucinous cystadenoma than a serous cystadenoma. It's got these big lobules to it. It is multiloculated and it's shiny. Because again, this is mucinous too. And then finally, we've got a solid pseudopapillary neoplasm right here on the bottom of this chart. And I want to show you a picture of this before I say anything about it, because you're going to have no trouble making the gross diagnosis on this. Is this thing cystic? Nah. So it's also going to bleed a lot. It's going to hemorrhage. And so you can see some of that within this bisected nodule. Very red, a lot of blood in there. So we look at the chart. What do we got going for these different neoplasms? Well, first of all, the solid pseudopapillary that we just looked at, it's like a golf ball basically, presents in young people, and it almost always, they're going to give you a female on the questions too. So that one is that one, and it's got a beta-catenin mutation, and that's the easiest one to recognize. Hemorrhage, young women, beta-catenin. No problem there, check. So then we're thinking about, well, what's the other one? Because we're left with 3. Well, then what's another one we can rule out? And I would say this serous cystadenoma is going to be the next easiest one to rule out, because again, it's microcystic. They have to tell you it's microcystic or show you in some capacity it's microcystic for you to make this diagnosis. And what they really want to ask you is, what's the gene associated with it? And that's the von Hippel-Lindau gene. So we'll get to there in a little bit. And then we're left with these 2 tumors in the middle that are fairly similar to each other in their appearance grossly. They're both going to be multilocular and macrocystic with mucoid secretions. So how do you tell them apart? Well, histologically, this mucinous cystic neoplasm is going to have tall columnar cells, and this intraductal is typically going to have just a normal cuboidal epithelium. Now, the intraductal mucinous neoplasm is also going to have attachment directly to the pancreatic duct. So again, if they want you to pick IPMN, they've got to tell you or show you it's connected to the pancreatic duct. And then mucinous cystic neoplasm, I didn't see any mutations for that. IPMN, we've got GNAS and APC mutations. Those are 2 you want to know and recognize. So we said APC, quick divergence. APC is not positive in ductal adenocarcinoma. Period. End of discussion. You see APC positive, it's not a ductal cancer. It's a cyst or an acinous carcinoma or a metastasis. So a cystic pancreatic neoplasm is defined as a uni or multilocular cavity-forming neoplasm composed of epithelial and or mesenchymal tissue supported by mesenchymal stroma. Most cystic pancreatic neoplasms arise from the exocrine components of the gland. They are benign or low-grade malignant neoplasms, and the prognosis is significantly better than with a ductal adenocarcinoma. So it's a neoplasm. What does that mean? It's got clonality and it's got hyperactive growth. However, it's not invasive, so it's not cancer. They tend to be slow growing and asymptomatic, and they've got a lot of different categories, and let's run through them. They're only 5% of all pancreatic neoplasms, which, I mean, what better cue could they give us? You know, like, obviously we're going to get a test question about this, 5%. So serous cystic neoplasms, you need to know the serous cystadenoma, which is associated with the von Hippel-Lindau gene being out. That is a tumor suppressor gene that ubiquinates hypoxia-induced factor 1A. And HIF-1A is a damage response protein, so it makes cells grow, right? Same as VEGF, basically. You know, you got VEGF, you're making new blood vessels, okay? You got HIF-1A, you're making new ductwork, period. So when inflammation is done and when you've healed the damage properly, you need to make HIF-1A go away. So you need von Hippel-Lindau, that protein transcribed by this gene, to crunch up that HIF-1A and get rid of it from the cytoplasm. So if you don't have that, your cells are constantly dividing because they think that you're constantly damaged, you know, or hypoxic. So von Hippel-Lindau syndrome has a lot of H's going on in it. Von Hippel-Lindau, HIF-1A, and HARP tumors. And what HARP stands for, it's an acronym. It's the 4 types of tumors you're going to get in von Hippel-Lindau. You're going to see hemangioblastomas, that's the H. You're going to see angiomas, that's the A. You're going to see renal cell carcinomas. And then you're going to see pheochromocytomas too, as well as pancreatic neuroendocrine tumors. So I suppose you could put 2 P's on the end of that, right? So it starts with H. Remember all your H's for VHL. It's autosomal dominant, and it's also a tumor suppressor gene. It's a loss of function. So they want to ask you about the association for sure. And again, the diagnosis is easy to make. It's microcystic and it's serous, meaning there's no mucin on histology. Each individual cyst is lined by a single layer of flat to cuboidal cells, just like a cavernous hemangioma, except that would be filled with blood. So kind of notice that overlapping architecture. Angioma is associated with this thing after all. Serous cyst is probably not going to turn into a cancer. A mucinous cyst, however, is likely to turn into a cancer. 10 to 20% of mucinous cystadenomas harbor malignancy. They tend to have KRAS and P53 mutations, but you're going to be able to guess that. I suppose I should add it to my chart regardless, which I shall. Mucinous cystic neoplasm is going to have KRAS and P53 mutations. So again, all 4 types of these cysts have associated mutations. They want to ask you about that. They really want to. If it's a mucinous cyst, it's going to have mucin in it, and you're going to see mucin on histology, just like you see on the right side of this image here. There's a layer of mucin, and on the left side of this image, there is mucin kind of embedded into that ductal cleft on the left side of that square. On the left side, you see we've got a macrolocular cyst, not a microlocular cyst, and it's got kind of a shininess to it because that mucin is in there, as opposed to the serous cyst, which looks a little bit drier because, again, there's no sugars up in it. It's not going to shine. So the fact they include these gross pictures of the tumor tells me they also want to give you a gross image and see if you can just make the diagnosis based on the image, or they can give you the gross image and say, what gene is the patient missing? You know, like what's the mutation in, you know? So that's the second order question for this. These cysts are always in the body or tail of the pancreas. So that's going to also tell you apart this from a ductal adenocarcinoma is that ductal adenocarcinoma, head, majority of cases, cyst, tail, body. And then finally, histologically, these cysts have tall columnar epithelial cells. So let's get back into some images here and look at the two we've covered already. The serous cystadenoma, low malignancy potential, von Hippel-Lindau gene with your HIF1A overactivation in your heart tumors, so your hemangiomas, angiomas, renal cell carcinoma, pancreatic nets. Grossly, very, very small spaces and no mucin whatsoever inside these cystic dilations. Now here's a mucinous cystadenoma. Notice it's got a fat, tall columnar epithelium to it, and you see mucus inside the lumen of that duct. Another gross look at it, it's a bigger cyst. It's a shinier cyst. This is going to make the diagnosis histologically. Look at that columnar epithelium. Not going to see that in a serous cyst. Not going to see that in an IPMN. You're going to see a bouncier epithelium in an IPMN. So here's that IPMN on histology. Again, how are we telling them apart? The squishiness, the cuboidalness of the epithelium, because if it's mucinous, it'll be columnar, but if it's this, it'll be flatter. What do we got going on for the intraductal papillary mucinous neoplasm? We got GNAS mutations and APC mutations, and they got to tell you somehow it connects to the pancreatic duct. Often, mucus can be seen exuding from a bulging papilla at the ampulla of Vater. So if an SDL says, oh, this often happens, what the SDL is telling you is, if you get asked about this, here is what's going to be in the question still. Take it to the bank. And then on the flip side of that, if an SDL has a pathology and they give you 10 symptoms for it, and then it's like, patients often present with this. Patients rarely present with this, and this. You don't need to memorize the rarely, you know, because they're not going to ask you about it. There's no way, because then 95% of the class will get the answer wrong if they ask you about something that not everybody has memorized. So if they ask you about the IPMN, they will probably tell you there is so much mucus in the pancreas that it is spilling out into the duodenum. That's the characteristic part of that question to me. Clinical presentation, that's not making the diagnosis. Mucinous stool, maybe. And then IPMNs also have a very high risk of turning into cancer. They have the highest of all of these cysts in terms of a risk of progression. Then we talk about the last one, solid pseudopapillary neoplasm. What do you need to know? They're going to give you a 30-year-old woman if they want to talk about this, 32, 34, you know, 28. She's going to have a beta-catenin mutation, and she's going to have this cyst that, again, is about the size of a golf ball, and it's solid, and it's hemorrhaging. That's it. So we get down to the last 2 pages of this SDL, tumors with acinar differentiation. We've got an acinar cell carcinoma, and then we've got a pancreatoblastoma. So both acinar cell cancers are going to have APC and beta-catenin mutations. Need to memorize that. Acinar cell carcinomas are going to be purple, purple, purple. They're going to look kind of similar to the medullary ductal carcinoma, but they are going to lack the desmoplastic stromal response. That's really big. That's really big. If you see something purple and looking like normal pancreas, and it doesn't have a lot of collagen in between individual lobes and ductules, probably this acinar cell carcinoma. because the number one feature of a ductal adenocarcinoma is that it's got all sorts of fiber holding it together. So this acinar cell carcinoma, the next clue they're going to give you is they're going to say, this thing stains positive for lipase. And you're just going to be like, well, there is no way that is a ductal cell cancer, you know? Might have zymogen granules on TEM or something like that. And they want to ask you, what's the mutation? You're going to say APC or beta-catenin, whichever one they list. Go with APC if it's both. Because, you know, at this point in my medical education, I would not put anything past people who write exams. Pancreablastoma, pancreatoblastoma, they're going to show you a child with a pancreatic tumor, and this is the only thing that can give you a pancreatic tumor in a kid. Same thing here, going to have APC and beta-catenin mutations because this is of Acinar lineage. Cut surface is bright yellow, again, in a child. Looks very similar to the Acinar carcinoma, except you have squamous nests, squamoid nests. And same thing, they're going to tell you it stands for trypsin or lipase or chymotrypsin, or that it has zymogen granules. They're going to give you one of those clues in the question. So what are they going to ask you? APC beta-catenin. They might ask you what's the prognosis. They really don't like asking that in path. But if they do, totally cool. Just take the cancer out, make sure it doesn't grow into anything else, and kid doesn't have cancer anymore. So that is carcinoma of the pancreas. Let me flip through here. Oh, here's a pseudopapillary neoplasm, and that's the golf ball one. And this is the hemorrhaging we're talking about. You see redness there. You see redness in a margin down through there, and on the right side of this screen, those are red blood cells. And another example, very red appearance, kind of in the interlobular fibrosity or spaces surrounding these exocrine lobes, and that redness is red blood cells. That's a beta-catenin mutation in that cancer. I would go back to this one slide and just encourage you to know the sequence of genes associated with the precursor lesions. I know it's not the most fun thing to learn, but it's going to make sense in your head after you do it. And you're going to be able to take the same strategy that you used to learn this and that you used to learn colorectal carcinoma. And I promise you that when we reach hematology, hem-onc, you're going to be doing this because, Lord, every single day we're going to be seeing a new cancer with a new gene, you know? So you're going to have to crank up this method of studying in the future. So put in the work now so that you're not drowning when we get to block 6 or 7, right? So thank you for your time.